in-house and for the 142 of you who are online. As you're aware, John gets us up and moving all the time, and that's why we do that. So everybody's music is a little different, but kind of gets you bopping around a little bit. And that's the idea. We need you all to bop around a little bit and get 150 minutes of aerobic exercise in a week, whether you do that dancing, whether you do that gardening, whether you do that swimming, jogging, or gardening. I have to put that one in there. I have to remember to put that one in there. And somebody got mad at me the other day. I have to include pickleball now. You're a pickleballer? Wow. Okay. So the highlight of our afternoon today is a presentation by Dr. Sanne van Rooij, who is an assistant professor in the Department of Psychiatry and a clinical neuroscientist. She directs the Stress and Neuromodulation Lab, and her idea is to identify predictors for post-traumatic stress resilience or resistance to stress, if you will, and recovery to develop brain-based treatments. So post-traumatic stress disorder has an etiology, and she is looking for a solution. I think that's a better way to do it, or how to prevent it in the first place. So at this time, I'd like Dr. van Rooij to come here and talk to us today. And she told me before this presentation starts, she really does like engagement and feedback. So look at her and do this for her.
Okay, perfect. Thank you all for being here today. It's really a pleasure to talk to you about and like discuss post-traumatic stress disorder and the brain. I organized this talk really about questions that I often get when I tell someone that I do research on PTSD and trauma. So I'm hoping that sort of addressing these questions will kind of give a good amount of information about PTSD and traumatic stress. So the first question that we're going to talk about is, what is the difference between trauma and PTSD? Who can develop PTSD? The third question I often get is, why do some people develop PTSD and others do not? Of course, we want to know if there's treatments available for PTSD, and then if there's also new treatments being developed. And finally, like, if you experience symptoms or if you know anyone who has symptoms, what can I do? So sort of like ending with that. And because I'm a clinical neuroscientist, I study the brain, and I really try to use that information to guide us in like novel treatments and better understanding what's happening. So in my talk, I'll integrate the brain and some of the mechanisms we study as well. And again, if you have any questions or anything is unclear, please raise your hand for those who are in the audience here. And there should be time at the end to address other questions as well. So the first question, what is the difference between trauma and PTSD? So a trauma, as we study it, is like experiencing or witnessing an event that involves either an actual or threatened death, serious injury, or sexual violence. So it's something that you experience that can be either of those things. And examples of trauma are, for example, a car accident, like a severe car accident, a physical or sexual assault, a fire, explosion, a hurricane, or a fall, something that either caused or threatened to cause serious injury or death, or again, sexual violence. PTSD is the psychiatric disorder that one can develop after they've experienced the trauma. So trauma can lead to PTSD. So what is PTSD, or post-traumatic stress disorder? So what are the different symptoms? PTSD is has a lot of different symptoms. It's not just one symptom. It's like 4 different clusters of symptoms that together, if you have one or several of those, gets you the diagnosis of PTSD. We also see that people have some of those symptoms and that can still be debilitating. But for the full disorder, you have 4 different types of clusters. So the first type of symptoms are intrusions, and intrusions are unwanted thoughts of the unwanted memories of the trauma. So, for example, flashbacks, which is something, if you've ever seen like a movie or something about PTSD, this is the most well-known symptom. So flashback means you're kind of back in a situation where the traumatic event happened. This is not the most common. It's actually a lot of people have PTSD without having flashbacks. Other intrusive symptoms are nightmares, intrusive thoughts, basically meaning you think about the trauma at a time you really don't want to think about it. Or if something reminds you of the trauma, you suddenly feel, very anxious or get like sweaty hands, or you start feeling very emotional. Those are all like intrusions. So the second cluster, second group of symptoms are avoidance, because it's very uncomfortable to have these intrusions. People try to resist that. So they either go out of their way to avoid something that reminds them of the trauma, or really try to occupy themselves otherwise, such that they don't think about the trauma. Then PTSD, if you have PTSD, you typically have changes in thoughts and feelings, such as less interest in what you used to enjoy, feeling guilty either about what happened or how things are going now. You may not be able to trust as well as you used to. And the last group of symptoms are hyperarousal symptoms. So people who have PTSD symptoms feel really on alert the whole time, like kind of scan the room maybe where they are, kind of looking for anything that's potentially dangerous. There's problems with sleeping and attention. If there's a sudden noise, someone will jump up or have like a really high startle response, as we call it. I'll come back to these symptoms in a little bit as well. So PTSD is not the only consequence of trauma. We know that there are several other disorders that coincide often with PTSD, so we call it comorbidity. People with PTSD often also suffer from depression, and we know that substance use or substance use disorder is oftentimes seen in those with PTSD, or at least there's some common risk. Then we also know there's increased risk for other disorders or symptoms. So we know there's a twofold risk of dementia if you have PTSD. We know that it increases the risk for negative reproductive outcomes like fertility, preterm birth, risk of adverse birth outcomes, cancer, cardiovascular disease, metabolic syndrome, diabetes, and obesity. And the schematic here, do you see my mouse? So you really see like downstream effects from the stress. Like it impacts the liver, the gonads, the heart, lymph nodes, and adrenals. So to summarize that, the difference between trauma and PTSD is trauma is the event, PTSD is a disorder, and PTSD is not the only possible consequence of trauma. Who can develop PTSD? Anyone who is exposed to a trauma can develop PTSD. I know I often get asked, like, I think we associate PTSD, we used to associate it with the military, with veterans, and I'll come to that later. It is indeed a group that experienced a lot of trauma and therefore has a high risk of developing PTSD. But anyone who has experienced a trauma is at risk for developing PTSD. And up to 90% of the general population will experience a traumatic event at some point in their life. However, within individuals experiencing trauma, there are risk factors related to the trauma that put you at greater risk for PTSD. So one would be not just one single trauma, but like repeated severe trauma exposure, having exposure to trauma already during childhood, or growing up in a very unstable environment. And also ongoing stressors can really increase the risk for developing PTSD, ongoing stresses such as poverty, of experiencing racism. And then another factor, we know that females are twice as likely to develop PTSD compared to males. So about 6 to 8% of the general population is diagnosed with PTSD at some point in their life. And we know that these numbers are greater in populations that are at risk. So those are the groups that experience repeated trauma, have ongoing stresses, as I was just talking about. So two of these populations are, as I briefly mentioned, veterans. So veterans have higher risk of developing PTSD. Often they experience like repeated and severe trauma, and there may be other factors contributing to that. And then a study, actually a long-standing study here at Emory, has really discovered that there's a high level of PTSD in a minoritized low resource population. And I put up a picture of Grady because that's where the research program is based out of. And I'll talk a little bit about that. So the Emory Grady Trauma Project is a large research program that has been investigated PTSD and traumatic stress in the civilian population since 2005. And we've recruited our participants from the Grady Memorial Hospital, which is serving primarily an urban dwelling, low-resourced, minoritized population. And this group shows some of the, is like mostly Black or African American, no college education, typically monthly, like majority has a low monthly household income. And so a great chance of like experiencing poverty, which is a continuing stress factor, high levels of reported racism and race-related stress. And in our studies, we've really focused on females. So in our population, we see that 80% report more than 2 types of trauma. That can, if you would have 3 car accidents, they would count as 1 type of trauma. So again, more than 2 types of events that were life-threatening or like led to either serious injury or risk of serious injury or sexual assault. And where the population, the US population has about 6 to 8% of PTSD, and where the veteran population shows about 31%. Ooh, I go too fast. The GTP, the Grady Trauma Project, showed rates of PTSD of close to 46%. So really showing that, you know, this repeated exposure and that trauma, like pervasive trauma, really has a high risk of developing PTSD. So again, anyone who has experienced trauma can develop PTSD, but there's a greater risk with more severe trauma and prolonged and stress. So why do some people develop PTSD and others do not? So if you experience a trauma, let's say a car accident, some people indeed develop PTSD. However, the majority of individuals is resilient, which means they maintain their mental well-being or recovery without intervention. So they're actually doing fine despite having experienced a trauma. And we see most people actually do fine. And maybe not in the beginning, but soon enough, they will sort of process the trauma and are doing well. And so this is very interesting and very relevant from a research perspective, because we want to know, why do some people do well? Because if we understand what contributes to doing well after trauma, we can like work with that for interventions. So that's one part of my research, really focuses on that. And kind of like explaining what happens with developing PTSD and then talking about how the brain is related to this. So let's say you've experienced a car accident and this brought you to the hospital. This is of course a very stressful event that you want to avoid in the future. So your brain is like really saving this information. If you've experienced something traumatic, your brain will remember it, because then it's important for survival. Like if you back in the day encountered a bear, you want to make sure you remember where not to go, where the bear is, or like really look out for signals. So it's really critical for survival to learn fear. So what the brain does, it really takes in all the information and integrates it. So the car accident happened on a busy highway. It was raining. So all of that information gets sort of saved. And so next time you're on a busy highway, your brain tells you like, okay, pay attention, because last time you ended up in a hospital. So this is really, you know, provoking this anxiety in the moment. So maybe when you're driving, your hands start sweating or you feel like really uncomfortable, which is very normal. Again, this is your body has learned, like your brain has learned that something like this was dangerous in the past. And however, maybe it was raining during your accident, but it's not raining today. It's like very sunny. And actually, you make it home safely. This is important because next time, sort of remember that. So while you've learned this fear memory, you can also learn this safety memory. So this time we call this fear extinction. So you kind of dampen your fear, you unlearn the fear, or basically learn this new safety information. So next time you're on the busy highway and you know actually you feel fine again, so you go home. Even if there's rain again, maybe the first time you feel a little bit nervous again because the rain comes, but then again, you come home safely and soon enough, you've extinguished, as we call it, your fear. You have unlearned the fear. So which brain regions are involved in this? This is where we're going to go to the neurobiology. So the amygdala is really critical in learning fear. So amygdala is sort of the fear center of the brain, and it tells you to pay attention. Like, okay, it's alerting you to fear, and it's really helps you to learn this fear. So again, the highway initially may trigger the fear response. Then we have the hippocampus. The hippocampus is important for contextual memory. So the hippocampus tells you, oh, but wait a minute, it's like sunny today. So like integrate this information. So it's kind of like integrating that. And then we have the prefrontal cortex. And the prefrontal cortex in the front of the brain is important for regulation. So basically what's happening is the information from the hippocampus and other factors tell the prefrontal cortex, okay, you can, this is not actually, it's very unlikely that we're going to get in a car accident today, so calm down. So basically the prefrontal cortex inhibits or calms down the amygdala. And that's what's kind of happening with fear extinction. So again, if you learn fear, your amygdala is really telling you, okay, this is dangerous. And then the prefrontal cortex with the information from the hippocampus is important for regulating or suppressing or inhibiting that fear. So what happens in PTSD? What goes wrong? So our research and other research across the world actually has shown the amygdala is overactive in individuals with PTSD. So it's really hard to calm it down. So it's, even if something is remotely scary, like it will already be on high alert. And then the hippocampus is not processing this contextual information as well. So it's not giving you that signal like you're in a safe environment. And the prefrontal cortex is not regulating it. So those three regions are really important in learning and unlearning fear, but in PTSD, you're not really unlearning it. And in fact, what's happening is the following. Instead of sort of unlearning this fear, you have impaired fear inhibition. So every time you go on the road, it actually gets worse. And, you may not have that feeling of safety anymore. And when you drive on like a quiet road, instead of something that where the car accident never happened, it may again give you that feeling as if you were ending up in a hospital. So it's kind of generalizes. And then if it's raining, even though you're not in your car, you're at home, the rain really brings you back to the event. And like you kind of remember when you were driving and the rain was, the rain is sort of a trigger for the stress. So basically what's happening is generalization. So where you went from this very specific event that led to this very specific outcome, in a good situation, you unlearn that. You're like, okay, this was just this one situation. But individuals with PTSD do the opposite. They generalize. So they now are afraid of a lot of things that are sort of remotely related to the original event. And then if we look at the symptoms, you may, when the rain, which shouldn't be a trigger for anything anxious, shouldn't trigger you in general, because the rain in and of itself isn't causing you pain, but you have associated with pain from the time that you went to the hospital. So, the rain itself may make you anxious. So you may avoid getting out of the house, or you may avoid getting on the road altogether, or avoid highways. And you can imagine that really influences your daily life. You may feel very like you may not have the ability to trust people, because the person who hit you on the car, on the road, basically you may generalize that, and then you feel like very on alert the whole time. So this is kind of like how PTSD can develop from a car accident. And that was a very long introduction to start talking about a study we did. So it started at Emory. We did a 5-year research study. Individuals who were brought to the emergency room were followed for a year. And 1 month after they had a trauma, we did an MRI scan where we looked at their brain and really measured which brain regions are like predicting who will develop PTSD. And then this study was built out in a really large nationwide study with 29 sites across the US, where again, individuals who were brought to the emergency room were included in the study and followed for a year. So we have almost 3,000 participants in this last study, with about 500 who have MRI scans. And the hippocampus, as we predicted, lower hippocampal activation, so lower engagement of this contextual information, predicted development of PTSD, and those with higher hippocampal activation were the ones with lower symptoms. And similarly, we found for the amygdala that indeed greater amygdala reactivity predicted developing PTSD at 6 and 12 months. And then we also looked at it a little bit broader, and I put this up here in case you want to read about it. So we, instead of just looking at PTSD, we looked at some other symptoms related to PTSD, like depression, like substance use, but also what do you do, sleep, and a lot of other measures, and sort of try to predict who's doing well across all of those measures. So that was recently published, and there's a little article about that. So why do some people develop PTSD and others do not? It's basically individuals who are not able to unlearn this fear and do not learn this like safety processing, are at greater risk of developing PTSD. So greater activation in the fear center or the amygdala, lower regulation, so lower engagement of the prefrontal cortex, and lower memory of contextual information, the hippocampus. So what treatments are available for PTSD? The recommended treatment for PTSD is trauma-focused therapy, which is really this fear extinction in a safe environment. So in people who are doing well after trauma, this extinction is happening naturally. If it doesn't, the therapist can help you with it. So you have, it's called like prolonged exposure, cognitive behavioral therapy, or you have eye movement desensitization and reprocessing. They all have you go back to that moment, and like in a safe environment, the therapist will walk you through it. So what they do is they activate the traumatic experience, pay attention to relevant information, again, like engage the hippocampus, and then integrate this information and learn new associations to regulate or dampen that fear memory. And this is effective. This is a great treatment if people are able to tolerate it. Which we know that for about 30 to 50% of people, they are either not able to tolerate or not, or do not respond. And, but again, if you do respond, this is like the #1 treatment at the moment. So because we know 30 to 50% of individuals do not respond, again, this is a really important research question. Why do some respond and others do not respond? So I have done some research really trying to understand the difference between those that respond and do not respond and identify mechanisms of response. So again, the amygdala is the region that has been found across studies to be responsible for treatment non-response. So here I created an overview of the whole literature with a model for PTSD, really showing that the amygdala is the center for treatment non-response. So greater amygdala reactivity. So when anything even remotely reminds you of the trauma and you are on high alert, it's really hard to downregulate. It's really hard to benefit from contextual information, and it's also really hard to tolerate treatment. The trauma-focused therapy is the available treatment to unlearn fear and create a new safety memory. But as I was saying, it's not perfect, and it's not perfect for everyone. That's why we're doing research here, which I'll talk to you about for like not other options for treatment. So a treatment that we're developing here at in the TMS suite here at Executive Park is a transcranial magnetic stimulation for PTSD. So transcranial magnetic stimulation, as you see here, is a coil placed outside of the head, and it induces a small electric current in the brain. It is FDA approved for depression, among other disorders, and it has shown positive effects for PTSD in prior studies. And it has a lot of advantages. So it's very safe. It's non-invasive. There's nothing going in the brain. And it works around some of the barriers of trauma-focused therapy. So one of the challenges with talk therapy is that you have to engage, you have to be willing to talk about it, but it's also cognitively demanding. So for some people, it's just very challenging. So TMS can be used instead, or it can be used prior to trauma-focused therapy. So thinking back about that amygdala, if it's too active, if we dampen it, maybe you are able to tolerate it, the trauma-focused therapy. Or maybe now, because your amygdala is not talking to you constantly, maybe now you can actually unlearn this fear. That's kind of like the reason we're doing this. So we're doing a randomized double-blind clinical trial. The goal is to have 60 participants with PTSD symptoms, and people who are in the study come for 2 weeks, 5 times a week, and then we have 2 sessions per day. Each session lasts 30 minutes, so it's a 30-minute session, 10-minute break, and another 30-minute session. This is what the schedule looks like. So we have like a clinical interview and MRI scans before and after to really measure, do we change the brain in a positive way when we deliver this treatment? Oh, MT? Oh, TMS. That is the transcranial magnetic stimulation, the treatment. Yeah. This one. Yeah, no, it's good. Thank you. Okay, so we, instead of just measuring symptoms, and because we're targeting like immediately the brain, we want to know if the brain is, we're improving the brain. So we do MRI scans before and after. We do startle, which really means like, do you respond strongly to anything that's threatening? We measure like your skin response. Do you, a really good measure of sweating. And so like if you get nervous or people start sweating. We've done EEGs, so measuring brain responses as well using electrodes, and we have clinical measures because we do want to know whether it's PTSD symptoms and other symptoms are improving. So briefly, a really novel component, and I can talk more or less about more about it if we want to, but so one really novel component of what we're doing here is, because we have a good idea of what's the preventing people from recovery from PTSD, namely that overactive amygdala, we want to target that specific area. So what we do is we use the scan that we do at the beginning of our study. We look at what the amygdala is doing, so these lines are like, what is the amygdala doing at rest? And then we look in the brain, which area is communicating with the amygdala. It's kind of like showing that same pattern for each individual. And that's where we're targeting, because we want to get to that amygdala, but the amygdala is very deep in the brain and we cannot get there with TMS. So we use this method to find the area on the outside of the brain that we can target with TMS that talks to the amygdala. So this is like a novel method, and we're testing it out. But the good news is we see really good clinical effects in our study so far, which I don't think I have a slide on, no. This is just a new picture from one of our studies really showing where we end up if we do this analysis. So you see there's a good bit of variability between individuals where we place the coil for the treatment. So our new treatments being developed. So one of the new treatments, there's more, but there's not enough time to talk about everything. So one of the new treatments that I'm doing is transcranial magnetic stimulation. And the goal is to dampen the fear center, to sort of facilitate this unlearning of fear. And then finally, what can I do? This is mostly a list of resources and some of our studies that are ongoing. So if you experience any of these symptoms, and the next slide, I'll put up sort of a summary, or if you know someone, there's different options. So probably, talk to a therapist, maybe the first thing you would do. But I also put up our TMS for PTSD trial if anyone is interested in either learning more about it or possibly like seeing if you qualify for the study. So that's this QR code, and this is a link for the website. But we also know there's other options too, like mindfulness. We've had several studies and actually have one study ongoing, knowing that mindfulness is a really effective way to better regulate and dampen your stress system, and is a really effective method, is really effective for PTSD. Then something entirely different, which I don't have time to talk about, and also not an expert on this, is psychedelics assisted therapy. Is like really novel, and it's also a study happening here at Emory using MDMA to dampen his amygdala and see if we can facilitate this talk therapy so assisting the therapy using medication. And then there's things that are good to build resilience. Yoga, walks, exercise, all of those things are really good at it's like strengthening your brain, reducing stress, and overall doing better. And again, if you have a therapist, or you can find a therapist, that's if you experience these symptoms, is probably a good idea. Then I put up a resource list for the Grady Trauma Project. So we have resources for a lot of different things. We do a really broad range, anything that has to do with trauma, stress, but also risk, and like it's really stress across the lifespan. So we have studies from measuring parenting and like pregnancy, the effects of hormones, and then we have studies on like across the menstrual cycle. We have studies in menopause, really understanding this very, very understudied area, and like, do we know how stress and PTSD are interacting there? And then those are kind of in addition to the treatment studies that we have ongoing. We have a resource list for this and many other things if anyone's interested. And for those of you who are in the audience, I brought some information related to PTSD, like a sort of like this one, sort of like overview, what is PTSD, sort of like the key symptoms is here, and then some like next steps that you can do, and some information on some of the studies that we're doing. And with that, I have a really large group of people that I work with, and that I always want to thank at the end of a presentation, because all of this work takes a lot of man and brain power. So always really grateful for everyone who contributes to any of these components of these studies. And thank you very much for being here, for your attention. Okay, yeah, I saw the... We have some mics here in the room. Okay, good. As well.
For some of the studies that I'm going to get an echo. The mindfulness study, PTSD. Can you address that? So it
how it works. Well, there's one study investigating its brain mechanism. So there's a lot unknown, but I think overall reducing stress and like strengthening emotion regulation and overall regulation really helps when you are in a stressful environment, or when something triggers you to sort of have that fear response. It helps you regulate that. So that's how that would work. Yeah. If you are in a situation where like one of the triggers, and like you feel the stress build up, like being more, like the deep breathing, for example, could really help in that situation to calm down, because it's a lot of PTSD is also your system is on high alert the whole time. You're kind of ready to fight or flight, or and so dampening that, a lot of symptoms are sort of a consequence of that. Yeah.
What's your question?
Do I know how it leads to dementia? I don't, and it's not something that I really know a lot about. But stress is like probably the interaction with stress is really what's causing it. And with PTSD, it's like the stress. You kind of keep the stress up because you constantly everything is stressful, and so the stress builds up. So you're like, we do know that the body is really adapting to being in this high state of stress, and that is like a cycle you want to break. And I think that's really what is contributing to all of those physical outcomes, negative physical outcomes. Yeah.
So we have, that was your question, right? Give one sec. We have a couple we want to address. We have a bunch on the audience and online. Why do children who have experienced sexual abuse develop attention deficit hyperactive disorder?
I don't have the answer to that, and I don't know. Like, so I can reason why they would have symptoms of ADHD rather than like maybe the official disorder. If you we have done research with children who experience a lot of trauma, and these children were doing well, but their brain is adapting to the environment that they're living in. So we saw individuals who are exposed to a lot of violence in the neighborhood, their amygdala, hippocampus, and VMPC were all overly engaged because the system is constantly you're constantly on guard because you have to be, and your body is adjusting. So in that moment, it's good for you to be constant on high alert because there may be danger around every corner. And you may like you may just try to make sense of everything. So I think your brain is adapting to the situation. So I don't know if it leads to ADHD or how that connection is, but like being in this hyperactive state and constantly ready to fight or flight because there's constantly danger, or you feel like you constantly have to be on guard, that may make someone really inattentive and like hyperactive, and you have this like hyperarousal symptoms. Like one of the symptoms here, like heightened arousal, is also risk taking, and it's like problem sleeping, and it's inattention, and it's like those are all symptoms that come with coping with these high levels of stress in your body.
Yeah, we'll do one more, then we're going to come on here. Does it correlate that the longer you have untreated PTSD, the more difficult it's to overcome?
So I don't know that that's necessarily true. The problem is typically once you sort of learn to live with certain symptoms, like maybe you adapt again to like being in this state of having PTSD. So I think it's harder to just break the habits that you've learned, right? Like avoiding the highway, or, this is just like one example. So I think the longer you've been in this state, it can be harder to unlearn that. There's not like the longer ago your trauma was, the less likely you are to respond to treatment. That's not necessarily shown, but I do think some other aspects that come with having PTSD are maybe harder to adjust to or something. Yeah.
I was wondering if you said that y'all use Grady, but since you mentioned that a lot of the people in military have a higher incident, do y'all not go to the VA, or can you not do that?
Oh, yeah, that's a great question. And sorry if that wasn't clear. So for example, my study with TMS, anyone who has experienced a trauma can participate in the research. I think what's really novel about the Grady Trauma Project, there is a lot of research going on in the VA related to PTSD. So we already had like a pretty clear idea of what it would look like. We knew very little about what it looked like in a non-veteran sample. So that's like one of the things that this project did, is like seeing if it's like a similar pattern across, or if it like has any specific. So yeah, no, we like, again, like from my TMS study, anyone who has PTSD symptoms, we have several veterans in the study. That's where the Grady Trauma Project has really, I think, internationally made anyone recognize like, oh, trauma is actually, it can happen to anyone, and it can really like cause PTSD in civilian population. So not anymore. Yeah, no, we've really opened it up. So where would you go here? Previous slide, which I don't there. So the Grady Trauma Project website has information about our studies. The Stress Neural Lab is specifically the TMS study. It's like the lab sort of within the GTP umbrella that I lead. But so yeah, so those two, and we have like links that you can fill out and see if you're eligible for one of our studies or one of our treatment studies, or even if you know, just studies on stress in general or hormone levels across the lifespan. If you want to, you know, contribute to science in any of those things, we have.
And we have several more questions. We'll take about maybe 2 to 3 more before we wrap. Can you explain why an individual might feel tired or relaxed after EMDR? Additionally, are there any difference in efficacy whether EMDR is done remotely or virtually?
So EMDR is eye movement desensitization and reprocessing, and there's it's very commonly used in Europe, actually. So I'm from the Netherlands, and the research I did there, most people received EMDR, and here it's people lean more to prolonged exposure. From a neurobiological perspective, I understand them to be very similar, because the main goal is to unlearn this fear and, like, you know, what I was talking about, so I don't have to repeat that. With EMDR, for those that do not know, the standard EMDR is if you go with a finger from left to right, and the idea is that you engage your working memory, which makes that's like the reprocessing. So if you then save your memory, you sort of have interfered with it. And there's still a debate and research going on whether that component brings something extra beyond the exposure. So the reason why you may be very tired or relaxed is it's exhausting. It's like trauma therapy is hard work. Like thinking about it, it's like really draining. So I think that is probably the reason why people feel really tired. I think relaxed is good because you kind of want to go through, you kind of build up to a point where you feel very anxious, and then like the therapist helps you sort of calm down in the therapy session. Yeah.
Great explanation. Can you clarify what is the distinction between standard versus complex PTSD?
Yeah, so complex is typical. Well, so here's where I'm not a clinician. I always have to say this. I hope I do this justice, but so complex, in my understanding, is often includes often like childhood trauma. It's often consequence of childhood trauma, and it has can include dissociation. So like instead, you know, trying to like get out of your basically escaping where you are right now, like mentally. Yeah, that's it. I'm not the best person to answer that question.
Okay. And if someone's PTSD is related to hearing loss due to military, what therapy would you recommend to lessen their anxiety due to it?
So it's hard for me to say any like specific recommendations, but I mean, again, like just standard would be to see if trauma-focused therapy would work. That is really the gold standard, and sometimes in combination with medication. But it could be, you know, if like hearing is a problem for the therapy, something like a TMS could be considered. The problem with TMS for PTSD is that it's currently not FDA approved, so it's hard to, yeah, it's not available yet widely. If it is available for depression, and that's how people sometimes get also treated for PTSD.
Gotcha. Last question. Is hypnosis a helpful therapy?
I don't know.
Thank you so much, Dr. Rooij. Let's give her another round of applause inside the room and online if we can show her some love. Thank you so much.